So, first of all, I'd like to thank you, Andrew, and the organizers for having us at this beautiful place and fantastic meeting. And I was given the privilege to present some of our results of a recently performed study. So, what I'm going to talk is this one slide that we've just seen 3 presentations ago, and that is occult CSF leaks during and very shortly after endoscopic sinus surgery. So these are my disclosures, but they have nothing to do with this presentation whatsoever. So do we actually cause small leaks during our standard procedures? And if we do they have any relevance for our patients? Well, we don't know. What we do know is that we cause really running leaks in about 0.2% of our operations, which is about 1 in 400 patients. And we don't know if those perioperative leaks really do significantly have an effect on our patients. The second problem in our patients is that we don't know how our tests perform when they're done in a blood-contaminated field. So what does occult mean? Occult means that there is no visible leak during the surgery, but there is also no clear discharge after surgery, and the patient has no symptoms like hypotensive headaches or meningitis. And occult does not mean false positive, so these are truly positive tests in patients who are not symptomatic. Why is it important to know about CSF leaks? Well, we all know that about 33% of our patients will get 1 meningitis annually, and that's not the primary CSF leak patients. It's more likely for those who suffer from a secondary leak. So one of our previous studies has shown that those patients suffering from traumatic leaks are more likely to have an early meningitis compared to those with a primary leak. On the other hand, we've heard that too, secondary leaks may close spontaneously, and that might have an effect on the decision making. We heard that too. We have 2 very widely used tests for CSF, one being the beta-2 transferrin test that is very often referred to as the gold standard. It is something very specific to CSF because it's produced by a CSF-specific neuraminidase, and you have to detect it by electrophoresis, which is a quite sophisticated test, takes quite a lot of time, and it's also expensive. A lot easier is a test called beta-trace test. It detects the prostaglandin D synthase, which has the highest gradient between CSF and serum and can be detected by laser nephelometry, which is a lot quicker and a lot cheaper. Both tests do require analysis of serum or blood simultaneously to exclude false positive tests. Now, what did we do? Well, we had a look at a series of patients where we prospectively placed a small neuropathy into their middle meatus after a standard FES procedure. We packed the nose afterwards with a northern absorbing pack, and then we removed it the next day and did a beta-2 transferrin test by electrophoresis. We followed those patients who were actually positive for 2 years, and we had 1 positive control, which actually was a primary CSF leak where we drenched the paddy in the CSF of the patient and then let some blood flow over it. So we had a very similar situation to our patients. So obviously all our samples were blood contaminated, and we almost finished at that line because none of our samples turned out to be positive, which was very much in line with what we've heard before. But interestingly, even our positive control was negative. So we had to rethink the testing, and and tried to increase sensitivity by lowering the threshold. How did we do it? We compared the sides, so we compared right to left, and by doing so, we could actually see much clearer differences in one individual and could lower the threshold. We used densitometry, so we could quantify the findings a bit better and increase, again, sensitivity. So our patients, we planned for 50, but we stopped at 30, and I will come back to that in a moment. We're all around 40 years of age. The gender distribution was equal. Most of our patients had polyps. Some of them had recurrent acute rhinosinusitis, and some of them had chronic rhinosinusitis without nasal polyps. We had about 20% of revision surgeries, and in 80% of our patients, the surgeon said I could identify the skull base securely. There was no obvious leak during the surgery, and you can see the surgery. So we most often done a sphenoethmoidectomy, and the positive cases were all found in ethmoidectomy cases, not a single one in an infundibulotomy. And all those cases were in the group of patients that where the skull base was identified. So 4 of our 57 samples turned out to be positive. None of them, however, suffered meningitis or any clinical symptoms afterwards in this period of 2 years. There was none of the tested patients that turned out to be positive with a second test. However, we lost one patient who moved to Germany about a year later, who was contacted by phone, could tell us that there was no problems, but she refused to come back to Switzerland for whatever reason. And we couldn't identify clear risk factors. Why did we stop after those 30 patients? Well, very easy. When we removed those neuropathies, there was always a bit of bleeding, but in 3 patients we had a really brisk bleeding when removing them the day after. So we had to report to the ethical committee, and then we found, well, we can't continue with that. We're already having positive samples and already having a good result. So we were not convinced by our own tests and went on to look for titrations in beta-2 transferrin and beta-trace testing, because in theory our test should be 100% perfect. But that doesn't account for the blood contaminated situation, and we've seen that you need 20% of CSF in your sample for your test to turn positive if you use beta-2 transferrin testing, whereas you only need 5% of beta-trace of CSF for the beta-trace to turn positive. So we do see leaks in a high proportion of patients, about 13%, so 7% of samples, while others have found lower numbers. Why is that? Well, some of the previous publications have looked at smaller surgeries done in local anesthesia, and probably they were facing the same problem, but didn't have a positive control. So maybe their tests were false negative and were just blood contaminated, and then their test didn't work as well. I think we can rule out pre-existent leaks, although we haven't tested for them, but it is very unlikely that 13% of our patients suffer from primary CSF leaks. So taken together, we found it an extremely high number of patients that turn out to be positive, but the test itself is very unreliable, so especially when it's negative, you can't tell if it's true. We don't recommend any testing for occult CSF. So if a patient is suspected to have CSF leaks after a surgery, you either have seen it and then you're sure, or then don't test while he's still bleeding out of his nose or her nose. And we actually abandoned beta-2 transferrin tests for our CSF leak patients due to the fact that beta-trace performed so much better. So if a resident asks you during the surgery, well, will I be sure that I can see a CSF leak if it happens? Well, you can't be sure because probably it happens much more often than you think, but if you can't see it, it's probably irrelevant. Thank you very much.